Africa Regional Echo for today. We'll be looking at outbreak management of cholera, being given by Dr. Anel. Dr. Sinkala has been our pandemic force response guy for the past, I don't know how many years, very involved in the COVID-19 outbreak, in the thick of things, and now we have cholera in Zambia, and he's very much involved. We're privileged and honored to have him share his experiences this afternoon and morning. And so I want to beg your pardon. I am at conference for public health in Africa, and so you hear quite a bit of noise in the background. And it's going on very well here. It's exciting. So much information going around. We just took time to be with us on this session, so bear with us. There'll be a bit of background noise here. So without wasting lots of time, we have quite a number of slides that we're going to share. We just allow Dr. Nelson Kala introduce himself, then he can go ahead and begin the presentation.
Hi, sorry to cut you. Just wanted to ask the hub team would join me.
Sorry?
Just wanted to ask the hub team, would Daniel be joining?
I'm not too sure.
Daniel.
Maybe.
We've shared details.
I am not too sure.
We've shared details and he should be joining.
Okay. Okay. We'll if we can wait next 2 minutes and then we start, because we have to check the interpretation before we start.
Okay.
Okay. Thank you.
All right. I sure hope none of that. Just I'll let them once he joins in, and maybe we could reach out to him and just ask what time they're joining. Thank you very much for that, Alet. In the meantime, Dr. Sinkala, go ahead and introduce yourself and begin the session. Thank you.
Thank you, Dr. Zyambo. Good morning and good afternoon to everyone on the call. My name is Sinkala Hanel. As has been introduced, I'm an infectious disease registrar based at Levi Mwanawasa University Teaching Hospital in Lusaka, Zambia. I do help with cholera case management, the focal point person for case management for the outbreak response that is currently going on in the country. I'm in my third year of infectious disease, and I'll be taking you through this session of outbreak management of cholera with focus on case management. So with that said, I'm supported by a panel of experts. Dr. Zyambo, you didn't introduce our panel of experts that we have with us today.
Yeah, please go ahead. Go ahead.
So we have Dr. Paul Zulu, another infectious disease specialist, also sits at ZNPHI and has been supporting the country with regards to various outbreaks, and Dr. Nyambe, another infectious disease expert that will be also supporting us on the call. With that said, I think we can get started as we have quite a number of slides. I will try and get through them as quickly as possible. For any questions, please post them in the chat and they will be picked up. So with that said, we'll get into our objectives for this session. So the session objectives is we'll look at the epidemiology of cholera in Zambia and Sub-Saharan Africa. Then we'll look at the outline of case management of cholera, and then we'll look at some highlights of the cholera elimination agenda with focus particularly to Zambia. So in terms of globally, the global picture of cholera, every year we have about 1.1 to 1.4 million cases of cholera, with about 21,000 to 143,000 mortalities annually, and that's a global picture. But when we look at that global picture, we find that Africa contributes only 20% of those cases, But in terms of mortality, we do contribute 80% of mortalities globally. Then when you look at the general picture in Africa, we find that most of the outbreaks are in sub-Saharan Africa, as can be depicted in the map on your screen. And Zambia is in that region. Zooming in on Zambia, we've had 32 outbreaks since the first cholera outbreak in 1977, and cumulative number of cases more than 100,000 with 4,000 deaths, giving us a case fatality of about 4%. Most of our hotspots in Zambia are Lusaka, Luapula, Copperbelt, Northern Central, and Southern provinces. And these mostly have areas where we have high populations or people living close to water bodies. In terms of this year, we've had a cumulative number of cases of 1,825 as of 28 November with 36 deaths, giving us a case fatality of about 2%. This still is above our target of less than 1%. 12 districts have reported cases this year, with 4 districts still in response mode. 21 cases were reported in the last 24 hours, with no mortalities reported. So we get into case management after briefly looking at a bit of the epidemiology. This is going to be our outline. We'll look at the case definitions, look at the microbiology and a bit of pathogenesis. Then we'll get to the clinical presentations, assessment of fluid status, treatment, and then we'll look at the discharge criteria, and then we'll throw in some differentials along the way. So before we get into the presentations, we'll get to our poll questions. I'll ask Kote to load the first poll question for us, and then we can give it some time. Dr. Zyambo, for the poll questions.
Thank you very much. So the first question is, sorry, these are not the correct ones. Apologies for that. IT, do we have the polls loaded, or maybe we can skip this session? All right, thank you so much. Now, what is the level of dehydration? Here's the history. Says a 43-year-old female presents with 8-hour history of 8 episodes of profuse watery diarrhea and multiple episodes of vomiting associated with abdominal pain, leg cramps, skin pinch is more than 3 seconds. Admission vitals are BP 87/48, pulse is over 107, and it's weak. And what is the level of dehydration for this patient? You can pick a choice. No dehydration, moderate dehydration, severe dehydration, or unable to determine. Yeah. Unfortunately, there seems to be the choices are not so very clear here. The poll question shared isn't. Okay, so I think let's just skip this one. Let's not use a poll, but you can post your in the chat box. You can take your pick. Which one is it? You can just post the number here. Apologies for that. I think the poll questions were not loaded in time. We do apologize for that.
All right, I think then.
Okay, so I can see people have picked severe. Yeah, so we can move on to the next question. Question 2.
Question 2 hasn't been loaded as well. I think we can move on to the in the presentation, as it will be loaded later as we go on.
All right. Okay.
So in terms of our case definitions of who is a suspect case of cholera, of course, we understand that in areas where the outbreak has not yet been declared, any person aged 2 years or older presenting with acute watery diarrhea and severe dehydration or dying from acute watery diarrhea will be treated as a suspect. Then in an area where an outbreak has been declared, any person presenting with or dying from acute watery diarrhea will be classified as a suspect. And we understand that children under 2 can be affected by cholera, and it must be treated immediately. And when there's an outbreak and children that meet the case definition, we need to report them to our surveillance unit so that they can follow them up for their epidemiological analysis. So in terms of the microbiology, Vibrio gram-negative aerobic bacterium, facultative vulnerable bacilli, as flagella. And then there are 2 serotypes of interest. Of course, we understand there are more than 200 serotypes, but those that are associated with epidemics, the O1 and the O139, with the O1 being the most predominant and the usual cause of outbreaks in the recent past. Then in terms of the inoculation infectious dose of the Vibrio, about 1,000 of the Vibrio usually will cause mild diarrhea. And then we understand that for the Vibrio to cause symptoms, it needs to survive the gastric acid of the stomach. If it survives that, then it will cause symptoms when it reaches your small intestines. If you pick up it with food, 1 million of the Vibrio, it will result in severe diarrhea. Same with water, and symptoms are going to depend on the dose as we move on. In terms of the clinical presentation, we understand that 75% of our patients that have infected with Vibrio will be asymptomatic. And this has a huge role in terms of the public health importance, because these will not present to the facilities, but they'll be out there shedding the Vibrio, hence emphasizing on the prevention measures, washing hands, proper use of toilets, and making sure that our wash facilities are on point. Then 20% will have mild or moderate infection, with 5% presenting with severe infection. And these are the ones that we usually present in our facilities. In terms of the clinical presentation, we know that it's a dehydrating diarrheal illness with loss of fluid and electrolytes. Symptoms will range from asymptomatic infection through mild diarrhea to severe hypovolemic shock and death if not presenting early. But of course, we understand that there are a lot of other things that can cause acute watery diarrhea, not just Vibrio. So in this slide, just some of the differential diagnosis for acute watery diarrhea. Enterotoxigenic E. coli being the most common cause of acute watery diarrhea, noroviruses, Campylobacter species, to name but a few. And then, of course, when there's diarrhea, we need to be able to differentiate whether it's watery or bloody, as that will have bearing on your management. So the usual causes of bloody diarrhea, we have our Shigella species, enteroinvasive E. coli, just to name but a few. Now, in terms of how do our patients present, those that come in with severe illness, because these are the ones that usually come to our facilities. So they'll give you a history of profuse watery diarrhea. They'll give you a history of vomiting. There'll be a loss of skin elasticity. They'll have dry mucous membranes. They'll complain of a feeling of increased thirst, increased heart rate. Some may present with muscle cramps. Others will be restless, irritable. Then depending on the level of dehydration, others may come in with acute renal failure. Their BP will be low. They'll present with a metabolic acidosis. There'll be severe electrolyte imbalances. As we know, in cholera, there'll be great loss of electrolytes, and mostly of our concern is the potassium, as it has the most bearing in the acute setup. Then others will come in coma, hypovolemic shock, and death if they present late. And then we understand that if untreated, 50% of our severe cases are fatal, but with proper treatment and fluid replacement, we can reduce our mortality to less than 1%. Now, the fluid assessment is one of the most important things in terms of managing our cholera patients. And so it's important that we are all up to breast with the assessing of our fluid status, as that is going to have a bearing on how we are managing our patients. So how do we assess the fluid status of our patients? So first of all, we need to check for presence of the pulse. We need to examine the condition of their eyes, their thirst level, and their skin trigger. And then we need to determine the status, and then we'll treat them accordingly. Now, how do we determine the dehydration status? Looking at the pulse, you check for the presence of the pulse, check for its strength. Is it the beat strong? Can you easily pick it up? Or is it a thready and weak pulse? A rapid, thready, or absent pulse will indicate hypovolemic shock, and this is going to necessitate that you quickly move in and aggressively manage your patient. Now, there are 3 levels of dehydration that we're going to characterize our patient in. 1, no dehydration, 2, moderate dehydration, and 3, severe dehydration. And these are going to have bearings on the fluid management, as we are going to see in the slides that are going to follow. So how do you say that a patient has no dehydration? When the patient presents to you, you do your examination, you check your vitals, and you come to the conclusion that this patient is awake and they are alert. The blood pressure is normal, their pulse is normal, good strong pulse. Their thirst level is normal, their eyes are not sunken. When you do the skin pinch, it goes back normally or less than 2 seconds. Once you assess your patient and they have these features, you can assess them as no dehydration, and we shall treat them accordingly, as I will show a slide shortly. For moderate dehydration, when you assess your patient, you check their body weight. They've lost between 5 to 10% of their body weight. Their blood pressure will be normal. Their pulse may be normal or it may be rapid. They will be restless or irritable. They will have sunken eyes. They will have a dry mouth and tongue. They will have an increased thirst. When you give them fluids to drink, they will drink eagerly. The skin pitch goes back slowly, more than 2 seconds. If it's an infant, they'll have decreased tears and depressed fontanelle. Now, just a quick one on the loss of body weight here. A general
So apologies, I think the team TH may have. Can you hear me? There may have been a break in our internet, and our colleagues at UTH may have disconnected. Just give us a few minutes. We'll start over again.
Apologies for that. We had a break in transmission. Dr. Zyambo, can you see my screen?
I can, thank you.
All right, thank you. So we were just discussing on the aspect of body weight. We said generally most people will not know what their body weight is on a day-to-day basis, as very few people do check. So on this one, it's kind of a bit tricky unless for patients that really know their body weight. But with cholera and the amount of dehydration that goes on and the amount of fluid loss that goes on, the patient will definitely tell you to say, this wasn't my body weight when I woke up this morning. And we'll get to see why that is when we move on to the next slide. Now, when we're saying this patient is severely dehydrated, they would have lost greater than 10% of their body weight. And this is because with cholera, you can lose more than 1 liter of fluid per hour in the first 24 hours. And if we go by our physiology, we understand that majority of our body weight is generally fluids, about 60 to 70%, depending on sex and age of your body weight will be fluid. So if you're losing 1 liter of fluid per hour, it means you're essentially losing about 1 kg of your body weight per hour, meaning you can lose 24 kg of your body weight in 24 hours, which is quite a huge amount of weight to lose. And losing it in fluid, which is a major concern of our body, is quite debilitating. And that's why we find that the mortality rates, if untreated, will be very high. Then, when you check your patient's blood pressure, you find that they'll be in hypovolemic shock, their BP will be low, pulse may be rapid, weak, or undetectable, with minimal or no urine output, as they would have lost most of their body fluids. Then when you look at the skin, it will undergo what is called tenting. It would have lost its normal skin trigger. When you do the skin pinch, it will go back very slowly or not at all. Mouth and the tongue are going to be very dry, and they will have very sunken eyes. Others may come in very drowsy, with some coming in as unconscious patients. So these severe dehydrated patients really need aggressive fluid rehydration in order for us to minimize their loss of life. And we'll see how we calculate the fluids as we move on into the section of treatment. Now, how do we treat our patients? So treatment is going to be done according to the dehydration status. So if you look to the left of your screen, the first row is talking about when you examine your patient. On the left far side there, if you examine your patient, they are well and they are alert. They don't have any sunken eyes. They're drinking normally. The skin pinch goes back quickly when it is done. In terms of assessment, these are the ones that we're saying, these have no dehydration, and we are going to treat them according to plan A. And what is the treatment for plan A? It's to maintain hydration. Again, when you examine your patient in the middle row there, you examine, they are restless, they're irritable, they have sunken eyes, they are very thirsty, they're drinking eagerly. The skin pinch goes back slowly, more than 2 seconds. These ones we're assessing them as moderate dehydration, and we're treating them according to Plan B. And our Plan B is giving them oral rehydration to replace the ongoing fluid losses as well as to maintain hydration. On the far right of your screen, you examine your patient, they're lethargic or unconscious, they have sunken eyes, they're not able to drink, the skin pinch goes back very slowly. These ones we're assessing them as severe dehydration, and we're treating them according to Plan C. Plan C, this is where we're now going to use our intravenous fluids in addition to the oral rehydration in order to replenish the fluid losses and to maintain the level of hydration once we have quickly managed the dehydration. So now, as we are examining our patients, other factors that we need to look into is we need to assess their mental status as well as when we are examining them. Now, after having assessed your patient and put them either as Plan A, Plan B, or Plan C, we need now to go into the rehydration of what is Plan A, what is Plan B, and what is Plan C. So, just emphasizing on rehydration therapy, because like I have mentioned earlier on, the major issue with cholera is the fluid loss. So a patient is losing a great amount of fluid. In one bout, they can lose more than 1 liter in an hour, and they can vomit quite huge amounts of fluid. So just with the rehydration therapy alone, we can reduce mortality to less than 1%. But the key thing is that this rehydration therapy needs to start in good time. Once we start it in good time, we'll find that we can reduce our mortalities to less than 1%, if not at 0. And this rehydration therapy can be started right in the home setup or in the community setup by use of what we call the oral rehydration points. Oral rehydration therapy, we're using oral rehydration salts is recommended, and 80 to 90% of our patients that present with cholera can be treated with oral rehydration salts alone. And then those that will require IV fluids, we can quickly also switch them back to oral rehydration salts. And these oral rehydration salts are easy to make. We have those fixed sachets that are made, and it can also be made in the household setup if they do not have sachets. Now, coming to intravenous therapy, Ringer's lactate is the recommended IV fluid of choice. And the reason for this is because of its electrolyte contents. Ringer's lactate has, of course, sodium and chloride. It has potassium, and it has calcium. It has the lactate, of course, and it has some bicarbonate in it. The bicarbonate and lactate help us to act as buffers and help to reduce the acidosis. And this is where the difference comes in with the use of the normal saline or the half-strength normal saline. These are less effective because for them, they only have the sodium and the chloride, and they don't have the buffer. And hence, when given, these can worsen the acidosis that our severely dehydrated patients will present. And then these also do not have the potassium that the Ringer's lactate has. Hence, in that area, will be deficient when we use the normal saline. Hence why Ringer's lactate is the recommended fluid of choice, as it has the majority of the electrolytes that we need, and it has the buffer that we need. Our dextrose, 5% dextrose is ineffective because the dextrose will be metabolized and taken up into the cells, leaving very little fluid into the intravascular space. And our main aim is to quickly replenish the intravascular volume. Hence, the D5 is ineffective. So you find for every liter of D5 that you give, only about 50% of that fluid will remain in the intravascular space in comparison to the Ringer's lactate, where a majority of the fluid will remain in the intravascular space. D5 should only be used in malnourished patients, and those are a special population whose discussion will be done later on. So now, getting back to our oral rehydration, we need to replace the estimated losses at 100 mils every 5 minutes, and we need to replace the ongoing losses plus 1 liter daily, and we need to reassess our patients every 1 to 2 hours. And the reason for this is simple. Patient's condition can change by the hour. At 1 hour, the patient was not dehydrated. At the next hour, they have moderate or easily tipping into severe dehydration. So that is essence of reassessing them. And then we know that patients may need more than 5 liters. Don't be scared to give it. Please, let's give it. Usually on an average in a day, very few people would drink more than 2 liters to 3 liters in a 24-hour period. But for our patients with cholera, they may need more than 5 liters. Please, let's not be scared to give it. Let's give the patients and let them drink, as this is what is going to save their lives. Now, when you have diagnosed your patient and said they have no dehydration and they're in plan A. We're going to treat them as follows, and I will not go through all the three categories. I'll just pick on one, the 2 to 9 years age group. So if your patient is aged 2 to 9, they have no dehydration, you need to replace the amount of fluids that they are losing, replace the amount of stool that they are losing by 200 mils of ORS per loose stool that they have. And whichever number of bouts they have, you replace with the correct amount of ORS according to the age as shown on your screen. For those that are greater than 10 years, these ones you give them as much as they can tolerate per loose stool. And the essence of this is just to maintain the level of hydration so as not to tip them over into moderate dehydration. Now, those that will come in with moderate dehydration, again, we need to provide ORS immediately according to weight and age. And the next slide I'll show you is going to show you the bands for the amount of ORS that you need to give. These we need to monitor them closely every hour for the first 2 hours, monitor their fluid input, ensure that they're taking adequate amount of ORS, count the number of cups that they're drinking, and you need to re-administer ORS after 10 minutes in case the patient vomits. So if you give your ORS, the patient vomits, give them a 10-minute break, and then restart the administration of ORS at the prescribed rate. In terms of fluid output, we need to monitor the number and the nature of stools, as well as the vomiters, so as we keep track and need to help us in calculating and seeing whether they're going into severe dehydration or not. Then after 4 hours of giving them our ORS, we need to reassess their hydration status and then see if they're moved from moderate to no dehydration or they've tipped over into severe dehydration, and we treat them accordingly. So for those that come in with moderate dehydration, you can administer ORS by nasogastric tube because these ones are conscious and they're able to protect their airway, provided they're able to protect their airway, as we don't want them to aspirate. Now, moving on to this image here, which shows a depiction of how we calculate the amount of ORS that should be given within the first 4 hours by weight and age. So for those that are greater than 15 years, which is the last bracket there, and their weight is more than 30 kg, these are going to need ORS of between 2,200 to 4,000 mils of ORS in 4 hours. And just like I mentioned previously, we know that people, on an average, they will not drink 4 liters of fluids within 4 hours. But with cholera, and based on the amount of fluids that were given, it's essential that we give the correct amounts of ORS, as this is what is going to save the patient's life. If we underhydrate the patient, we're going to prolong the duration of illness, and we are going to tip them over from moderate into severe dehydration, where management is going to get a bit more complicated. For those that are between 2 to 4 years and weighing 11 to 15.9 kg, you give them between 800 to 1,200 mils of ORS within the first 4 hours, and we monitor them as previously discussed. If the weight of the patient is known, you can calculate the amount of ORS by multiplying the patient weight by 75, and that will give you the amount of ORS that you're going to administer to your patient within the first 4 hours. When the weight is not known, you can use the age, and you can use the age brackets as shown in the figure on the screen. Now, for those that come in and we assess and we see the severe dehydration, how are we going to manage these ones? So for severe dehydration, we're going to give intravenous fluids rapidly until the BP is normal within the first 3 hours. Of course, using 2 intravenous lines. For adults, we need to give fluids fast, and we'll see in the next slide on how we're going to give our fluids. Ringer's lactate is the best fluid, as like we have discussed, and use a new IV set for each patient for IPC measures. Then give ORS as soon as the patient is able to drink, and like I mentioned, only give it if they're conscious. Do not use the oral or the nasogastric route if severely hypovolemic or unconscious, because we don't want our patients to aspirate. Once they're able to drink, give ORS at 5 mils per kg per hour simultaneously with our IV drips. Now, calculating how we're going to give our IV fluids is very essential, as this has a bearing on the outcomes of our patients. So for patients that are greater than 1 year old, and we want to calculate how much IV fluids we're going to give them. So the calculation is that in the first 30 minutes of you receiving the patient, you're going to give them 30 mils per kg of IV fluids. Now, I'll use an example. 30 mils per kg for a 70 kg patient is going to result in you giving your patient 2,100 mils of Ringer's lactate within 30 minutes. And this is in the resuscitative phase, where we need to replace the fluid that the patient has lost very quickly and very swiftly. We need to ensure that 2,100 mils for a 70 kg patient is given within 30 minutes. And all these 2,100 mils has to go in. If it doesn't go in, then we're underhydrating our patients and we're going to prolong the duration of illness and we're going to worsen the prognosis of our patients. So within the first 30 minutes, we give 30 mils per kg. Then within the next 2.5 hours, we're going to switch to 70 mils per kg in 2.5 hours. Now, for our 70 kg patient that we have used as an example, if we give them at 70 mils per kg in 2.5 hours, we're going to give them 4,900 mils in 2.5 hours. Again, this 4,900 mils, colleagues on the call, has to go in 2.5 hours. If it doesn't go in, we're underhydrating our patients and we're worsening their prognosis or worsening the duration of illness. So within the first 3 hours of you receiving the patient, you are going to find that you would have given 2,100 plus 4,900. We are going to have given our patients 7,000 mils of IV fluids or Ringer's lactate, or 7 liters of Ringer's lactate in the first 3 hours of receiving our patient. On average, as clinicians on our wards, we usually give our patients maintenance dose of 3 liters in 24 hours. But here we are saying we're giving 7 liters in 3 hours for a 70 kg patient. And so we see that the amount of fluids that we're giving our patients are huge. And that's why we emphasize to say for cholera, it's better the management starts in the household so that we don't have to get to this point. But if our patients come in severely dehydrated, colleagues, I urge you, first 30 minutes, ensure we give it at 30 mils per kg, and then in the next 2.5 hours, 70 mils per kg. Thereafter, we reassess our patient and determine the level of dehydration and then treat them accordingly. For those that are less than 1 year old, the calculation changes slightly in terms of time duration. The first 30 mils per kg, we're giving it instead of 30 minutes, we're giving it in 60 minutes or 1 hour. And then the 70 mils per kg, we're giving it in 5 hours. And again, I emphasize, once you calculate the amount of fluid that you're going to give your patient, please give the IV fluids accordingly and make sure that they go in. If there's need for more than 2 infusion lines, please let's make sure we put in the infusion lines and hydrate our patients, as hydration is what is going to save our patients. Continuing on intravenous rehydration therapy, we need to monitor the pulse and stay with the patient until we have a good, strong pulse. We need to reassess hydration status at 30 minutes, then every 1 to 2 hours until we complete rehydration. Check for a rapid respiratory rate, as this may be a sign of possible overhydration or pulmonary edema. Once you notice that, make sure you sit your patient up and slow down on the IV fluids, and this should be able to resolve. We need to add the oral solution as soon as possible, and we need to continue the IV fluids when the patient is stable and drinking after we have finished our hydration, IV hydration phase. In terms of the management and recording, again, we need to record the inputs that were given of IV fluids and the ORS. We need to mark the quantity that we're given, ensure the cup and the ORS are within reach so that the patient should be able to drink freely as soon as they are able to. Then in terms of the output, we need to record the volume and the nature of stools and record the presence of urine, as it will be a good indicator of hydration status of our patient. As they're able to pass urine in terms of quantity and volume, we'll be able to see that we're getting to our hydration that we want to. Now, moving on, we understand that for every disease, there are always complications that come through. So in terms of complications that we need to watch out for, in young children, we need to watch out for hypoglycemia, and this can present with lethargy and convulsions. Early ORS administration and feeding can prevent this. Treat with glucose where indicated, but we're not saying stop running your IV fluids and start running your D5 containing solutions. No, treat the hypoglycemia separately, as well as continue running your Ringer's lactate on the other IV lines. In the elderly and in young children, again, pulmonary edema is a common complication that we need to watch out for. So you need to watch out for a new onset cough, rapid breathing, while they're on IV fluids. Just slow down on your IV fluids and sit your patient up as you administer it, and then you notice that this will go down. If you notice that the pulmonary edema is worsening, you may need to escalate the level of care to your senior colleague, or the senior most colleague on duty, so that they can consider whether to use IV furosemide or not. In terms of hypokalemia, as we explained earlier, IT, kindly help me to mute those that are muted. As we noticed earlier, there's hypokalemia because of the electrolyte loss, and this will present with painful leg cramps. Once we give in our IV fluids, our ringer's lactate has a 4 milli equivalents of potassium, and it should be able to correct this, and our ORS as well should be able to take care of this. So hence our emphasis on quickly administering our ORS and our ringer's lactate being our fluid of choice. Other complications that we need to watch out for, those that have prolonged shock may present with pre-renal failure, and you need to monitor their urine output like I mentioned earlier. Urine output should resume within 6 to 8 hours with correct hydration. And then those that, of course, may tip into renal failure, you may need to then refer them to a dialysis unit or to a renal unit for further evaluation and possible dialysis if indicated. For our pregnant women, there's a risk of miscarriage and stillbirths, especially in the third trimester, for those that present with severe cholera. But treatment remains the same in terms of fluids of choice, and ORS we still do the same way that was mentioned earlier. Those that are receiving IV fluids for more than 3 days, we need to watch out for infections at the site of the IT. Can you help with those? So in terms of redness, swelling at the line of the IV sites, you may just need to change the site of cannulation. Then in terms of what are the signs now that we have adequately hydrated our patient? We have discussed how to assess the hydration. We have discussed how to treat the various levels of dehydration, and we have discussed the complications. So what are the signs that you are adequately hydrating your patient? So the signs that we're going to look for are, one, you look for the skin pinch. Is it going back normally when you have pinched it? You check for the thirst level. Has the thirst level subsided? Have they passed urine? They have a good, strong pulse. Then you know that you're adequately hydrating your patient. And these are some of the indicators that we're going to be using, even when we come to dehydration. Now, colleagues on the call, you agree with me that we'll spend the greater part of this discussion just talking about ORS and IV fluids in terms of management of our patients. We haven't discussed anything on antibiotics yet, because like I mentioned earlier, 90% of our patients will treat them with ORS. And then 99% of our patients, just by rehydration alone, we are going to save up 99% of our patients. And we can get to 100% if our patients were presenting early. Now, there are those that are going to come to our facilities and we assess and we say these are severe dehydration and they may need the use of antibiotics. So now, talking about antimicrobial therapy. Antimicrobial therapy from studies that have been done has been shown to reduce fluid losses, has been shown to reduce duration of illness, and it has been shown to reduce duration of carriage. Antimicrobial therapy is only recommended for severe cases. And then the key thing with antimicrobial therapy is that resistance pattern can change over time. Hence, we're not going to be using the same antibiotics throughout the outbreak, or we are not using the same antibiotics that we have been using. And this is because the resistance pattern may change. Hence, emphasizing the importance of why we need to close the work between the case management team and the lab team, and periodically collect samples for culture and sensitivity so that the lab can tell us what is the current resistant pattern and the treatment that is appropriate for our patients. Antimicrobial therapy is not recommended for prophylaxis. There is no role for mass chemoprophylaxis in cholera. We see mostly some healthcare workers tend to abuse antibiotics, and generally the people out there, they take antibiotics in the name to say, no, these have been taking them for prophylaxis because they've heard that there's cholera. Colleagues, I'm here to tell you that there's no role for prophylaxis for mass chemoprophylaxis of using antibiotics for cholera, as it has no role and it has shown to have no benefit on the outcome. Now, talking about antimicrobials, which antimicrobials are recommended? So WHO recommends the following. For adults who are not pregnant, just a start dose of doxycycline at 300 milligrams per oral, and then there are alternative antibiotics that you can use in the event of no doxy. For pregnant women, azithromycin, 1 gram as a start dose, or erythromycin has the alternative dose that we can use. And you can read through the other alternatives. And then remember, like I mentioned, resistant patterns can change as the outbreak progresses. So you need to be working hand in hand so that the lab can tell you which antibiotics to use at that time of the outbreak. In terms of our pediatric population, we know that zinc reduces the severity and duration of most childhood diarrheal illnesses, and it's the same thing that applies with cholera. Zinc has been shown to reduce the severity and duration of cholera by approximately 10% in our children. And so for all our pediatric age population that come through, zinc supplementation, 10 to 20 milligrams zinc by mouth per day should be started immediately we admit such a one, and it has been shown to have good outcomes in our pediatric age population. Here, colleagues, is just a depiction of a cholera treatment center that we've had in one of our facilities. You can see the number of cholera beds with patients on the beds. There's some drip stands, buckets underneath the beds as patients. The diarrhea is usually effortless and you have no time to walk to the bathroom. We would have already messed up. And so we emphasize on IPC, proper infection and prevention and control in our cholera treatment centers or our cholera treatment units, emphasizing on separating our males and females, and then making sure that our patients are comfortable and they are warm and we are hydrating them accordingly. Now, just to summarize the treatment that we've been talking about, for those that you've assessed and you are saying they have no dehydration, we maintain them on ORS just to maintain hydration. For those that are moderately dehydrated, we maintain ORS to replace the losses. Once they are in no dehydration, we maintain the hydration status. Severe dehydration, we give them our IV fluids. Ringer's lactate is our fluid of choice. Quickly switch them to ORS when they're able to tolerate antibiotics for the severely dehydrated ones. Monitor for treatment complications that we discussed. Zinc supplementation for all our children. In terms of maintenance of hydration, when our patient has been adequately hydrated, we need to switch them to ORS to maintain their normal hydration status. And then once they're able to maintain, we need to start preparing our patients for discharge. So now, how do we know that our patient is ready for discharge? So for those that came in with severe dehydration and you admitted them, you need to look out for three things. One, they don't have any signs of dehydration as discussed earlier. Two, they are having 3 or less liquid stools and not vomiting in the last 4 to 6 hours. And three, the patient or the person taking care of her or him has demonstrated that they are able to take a maintenance therapy at home without any supervision. And in case symptoms worsen, they're able to return to the facility. If your patient meets those 3 criteria, then you are safe to discharge them. Those that came in with some dehydration, again, looking out for no signs of dehydration, no vomiting in the last 4 hours, and they have someone that can take care of them, they're able to take care of themselves, then you are able to discharge them. Those that came through with no dehydration, you've observed them for 4 to 6 hours, you can discharge them if they're able to drink sufficient amounts of ORS after each stool, and they're easily able to return if their condition deteriorates. So that is the discharge criteria, and in a nutshell, that is how we manage our cholera cases in our various treatment centers and treatment units. Now, colleagues, moving on, just to look at some key highlights of the cholera elimination agenda. Some major milestones that we have achieved in terms of the cholera elimination agenda. In 2018, Zambia did propose a resolution to end cholera by 2030. And Zambia itself has set a target of ending cholera or eliminating cholera by 2025. We did a hotspot analysis and mapping using the multi-sectoral cholera elimination team. We've mounted an effective response throughout the outbreaks from 2018. And then we launched our MSEP, and we've been making other steps towards eliminating cholera by 2025. Within the last 12 months, what has happened? Our president, His Excellency, Mr. Hakainde Hichilema, was appointed the Global Cholera Elimination Champion, a role that he has accepted and embraced. And at the current ongoing public health conference that Dr. Zyambo, you are attending, the president did mention that no one should die of cholera and that we should be able to eliminate cholera by 2025 as a country and by 2030 globally. And he's equal to that task and he's championing that agenda. And then we've implemented the use of the incident management systems in our public health outbreaks with over 80 districts trained in the use of the IMS as a country. In terms of our governance structure, the cholera response in our country is anchored in the highest office for disaster response in the office of the Vice President, of course, superseded by the office of the President, who's our global champion. Then we have the council ministers, permanent secretaries, and then we have our incident managers with the secretariat at the ZNPHI. these are the ones that are anchoring leadership and coordination. Then in terms of key achievements, we've done training in IMSs. At the current public health conference, we successfully held a cholera side event where the Minister of Health for Zambia, Honorable Sylvia Masebo, was our guest of honor, and we had Director General from ZNPHI, Zambia, as well as from the National Public Health Institute, Nigeria. We have incorporated the cholera tracker to help us in surveillance, and there's been a lot of investments in our WASH and community engagement from our partners, and we are doing a lot of research with collaborations with various partners that we have. What has been done in terms of WASH, WaterAid among its partners has been working with Ministry of Water Development and Sanitation and other stakeholders to support the 71st WHA resolution to end cholera. Then we've developed various initiatives such as the Pua campaign, which has been going on. Then we've had multiple OCV campaigns in Kanyama, in Monze, in Vubwi, and in Sama. And then we have help with partners to construct model HH toilets and scaling them up to 1,200 using finance model. An example is Kanyama, you can see in the depiction. And then we will continue to advocate for an increase in terms of the budget to WASH sector, highlighting the cholera hotspot in areas of need. And we continue to support capacity building for staff in IPC, case management, lab and surveillance, and RCCE as part of the multi-sectoral cholera response. So those are just some of the highlights in terms of what we have been doing in our way to eliminating cholera by 2025. With that said, Dr. Zyambo, I hand back over to you. This was my last slide. Thank you very much.
Thank you. Thank you so much, Dr. Anel. I appreciate your work that you put in and just to put these slides together. Thank you very much. Dear network, we would like to invite you to ask your questions if you have any. Check the chat. I haven't seen any questions.
Got a question.
Please, Amos.
I would want to know which among the vaccines, which one is the best?
Sorry, repeat your question.
I'm saying I would want to know which vaccine is the best for cholera.
Oh, okay. All right. That's an important question. Thank you very much. Dr. Neo, there is another question that antiemetics, do they play, and antidiarrheals, do they play a role in cholera management?
Thank you. Thank you, Dr. Zyambo. I've taken note of that. Then we can respond.
Okay. I'm still searching if there are any other questions. Any other comments, network? I think we can pick out on those two. I do hope our experts are around. They can also give support. Thank you. Dr. Anel.
Thank you for that question. I think the first question the colleague was asking on which vaccine is the best. Maybe I'll pass that one on to Dr. Mber to comment on the role of vaccines and which ones are the best. Then for the role of antiemetics and antidiarrheals, generally, no, we don't have any role for antiemetics or antidiarrheals, as mostly just with our adequate hydration, we will usually, the Vibrio will be cleared out and it will resolve. Duration of carriage has been shown to be usually between 2 to 5 days at the most. If it extends to the 7 days, so there's no role. Then I've seen in the chat where the colleague is asking how we can prepare homemade ORS since management needs to start from home. So for the preparation of homemade ORS, you need 3 items. One, you need safe water, safe and clean water that has been either boiled and cooled or chlorinated. Then 2, you need sugar, and 3, you need salt. So how you're going to constitute this? So you get 1 liter of your safe water, and to this 1 liter of your safe water, you're going to add 6 teaspoons of sugar. And now these spoons are going to be leveled. So when you scoop your sugar, that heap which forms on top, you need to level it out. And then you add your 6 to your 1 liter of safe water. Then for your salt, you're getting half a teaspoon of salt that is also leveled, and adding it, and then you mix it, and then you are able to drink, and that is quite effective. Now, I must mention that in terms of the ORS, once you have your ORS and once it is constituted, if you're able to refrigerate it, you can keep it for a period of 24 hours. If you're not able to refrigerate it, you can only keep it for a period of 12 hours. Thereafter, you are going to have to make a new constituent of ORS. Those were the 2 questions, Dr. Zyambo. Dr. Mbewe, Dr. Zulu can add on to the other responses.
So yeah, so I am with Dr. Zulu here. Yeah, I hope you can hear me. I think he'll speak to the vaccines.
Yes, we can hear you. You can go ahead.
Oh. Okay. Apologies, I was stuck in another thing, so just at the end. So not very certain what the question is, but looking just at vaccine immunogenicity. But the thing I can mention about vaccines is most of them have very similar efficacy, though and immunogenicity to speak of, though the recommendation as of now is still a 2-dose vaccines, which most of I think there are like 2 or 3 brands that were on the market. We used to use was a 2-dose schedule, and that is what is still recommended. But from guidance from WHO, because of the reduction in the global stockpile, they are now recommending a 1-dose schedule, which gives you protection, but a shorter duration, which usually will last about 6 to 9 months, while the 2-dose schedule is supposed to last 2 to 3 years. That then will mean then we need to rethink our cycle for putting certain you have already mentioned, which are to deal with control of cholera. So your vaccine is not meant to be your panacea, a cure for all issues, but it's just meant to be a stopgap measure as you try to bring in the others like IPC, WASH, strengthening case management, and the like. Thank you. Over.
Thank you so much, Dr. Zulu. He just happened to be around and the question was asked. Thank you very much.
Thank you.
Any other comments, questions from the network? We're coming close to wrapping up our session.
There's a comment in the chat where one of the colleagues is talking about garbage disposal and basically emphasizing on the WASH aspect as we try to eliminate cholera. So and then they say,
sure,
so garbage across the entire city. This is expected to worsen in the rain season as marketeers dispose of rotten mangoes, maize, indiscriminately causing flies to breed. Yeah, I totally concur with your line of thought about how we need to make sure that the garbage disposal services are up to point. And this is where the multi-sectoral elimination plan for cholera comes in. So it's just not a problem for the Ministry of Health, but it's generally a problem for the entire country. And hence, when we talk about eliminating cholera, we're just not looking at the healthcare workers, we're also looking at our engineers, we're looking at the local councils, and everybody has to come in on board. And so this is one of the risk factors for the spread of cholera, and it's well noted, and I'm sure the other people on the call that are responsible for this sector can follow it up, and we will be highlighting it to them, but just emphasizing on the need of a multi-sectoral response to cholera elimination. Over to you, Dr. Zyambo.
And that's a very critical point actually to take note of, and it is indeed our I hope that as we in the region continue to fight this disease, we'll continue to collaborate across board, sure that to ensure that we really come up with the proper elimination agenda. So, Dr. Anel, I'm a pediatrician, and I wouldn't comment on this one, but do we use zinc sulfate in adults? There's a question here.
Well, that's a good question. In adults, generally we're not using it in adults, but there's no harm if you want to give it. But basically, the zinc is to aid in re-epithelialization of the GI tract, and that mostly we want it in our pediatrics. In adults, we generally don't have that problem of re-epithelialization, so hence why it's not even recommended. But for our pediatric population, you're a pediatrician, you can speak more to that on why we emphasize on zinc in our children. So I'll throw it back at you.
No. That's just it. It's just to support the reepithelialization of the lining, and reabsorption and regeneration. That's okay. All right. So I don't see any other questions and comments. I think that being said, we can actually call this a day now. Thank you very much for running us through this important session. Like usually in the sub-Saharan region, we are all fighting this disease, and I think it would be good to hear from other colleagues on how they are running and working in the region, if they're able to speak to. I think a few months Malawi present on how they responded to the outbreak, and we do know that different countries are experiencing the same challenge. So we hope this has been helpful in help equipping us and learning from what Zambia is doing. So that being said, thank you, Dr. Sinkala. Thank you, Dr. Zulu, and all those that have joined in this afternoon. We say do day. Malaika, you want to make a comment?
No, I just want to say thank you everyone for joining. Thank you so much for this session. And I have shared the feedback form in the chat. So everyone to please fill the feedback form. And thank you all. See you in the next section. Thank you.
Thank you and have a good day.